Let's walk the talk.
This is Clement Manyathela
On 702.
Minister, thank you so much for making time for us. Good morning.
Morning, Clement, and morning to the listeners of 702.
I know you are quite busy. You are going to be hosting. How many ministers are you hosting today from all over the world as part of the G20?
Well, G20 means 20 ministers.
All of them get represented, or they send their representatives?
It differs. Some send deputy ministers. Others are represented by their embassies. Yes. Others, like the US, as you know, they always play these games. They told us that they are sending some senior officials in the department. So
Okay.
we'll see.
We'll see. I want us to start off with the proposals that have been made by the department, the funding proposals to implement this long-awaited national health insurance, because there are a few people that have raised some concerns about them. My understanding is that part of the proposal is to scrap medical tax credits, redirect subsidies to civil servants for medical aid, and there's also the talk of the introduction of payroll taxes to establish a national health insurance. Can you first clarify if these indeed are the proposals towards funding the NHI and what informed them, if that's the case?
These are not my proposals, Clement. They are in the Act. It's Section 49 of the Act. When Parliament passed the Act, there has been this section. It was passed with the Act. When the President signed it into law, all those things were there. What happened last week is that the Appropriations Committee in Parliament called us to come and clarify that. So we're just reading from the Act. We're not coming with anything new. I saw in the media it was as if we are coming with new proposal, which are just, catching from our heads. It's the Act. It's the implementation of the Act. Because that Section 49 were proposals. In the final analysis, the person who will take decisions on that is the Minister of Finance, is the Treasury.
Okay.
But coming to the issue of tax credits, that one I can clearly tell you with my eyes closed. We have been looking at it for ages, and we are not the only ones. Even during the time when the GNU started, the leader of the DA, Minister Steenhuisen, wrote a letter to the President to propose what he regarded as alternative to NHI. That means instead of NHI, this is what you must do. He made 6 proposals. On top of that list was this medical tax credits, the rebates, that they must go away. But unlike us, he gave a figure and say anybody earning above this should not be getting this tax credit. That's his first proposal among the other 5, which I don't think is necessary to mention. But even during the debate on, you remember, maybe let me say it's a war, about 2% VAT increase. Yes, quite a number of parties were proposing that instead of increasing VAT, if you are looking for source of money, you can look at the medical tax credits and abolish them. The reason that it is so, Clement, is let's look at the origin. What was the rationale of putting tax rebates or medical tax credit on medical aids? The reason was that, and it didn't start with us. It has been there right throughout the apartheid era, since medical aids were there. The logic, which I believe, I can tell you upright, was wrong, was that it was believed that if you encourage as many citizens as possible to join medical aids, and then you entice them with tax credits, or if you join a medical aid, will give you tax rebates or tax credit. If you do so, many people will line up to join medical aids. And when they are sick, the state does not have to take responsibility for them. Because they've been given something. They must go and buy their own health elsewhere because the state has given them what is due to them. It's more or less like in the Bible about the prodigal son, if you remember, who told the father that you give me everything that belongs to me. I leave you alone. You don't have to take care of me. You'll take care of the other children. Me, you'll have given me my portion.
Mm-hmm.
And he went away, but you know,
he ended up coming back. Yeah.
Well, now to believe that a government anywhere in the world will have a right not to take care of its citizens when they are sick because it gave them tax credit. It's not practical. Nor is it desirable. It was a very wrong thing to do. That's why they are always being targeted.
So what about the payroll taxes then? How would that work?
Well, it does not have to work, actually. It doesn't have to be. We're just showing several sources, if you understand what I mean. For instance, I believe one of the sources we are looking at, apart from medical tax credits, are the medical aid subsidies. Everybody who draws their salary from the state, everybody, starting with the president to the lowest worker, as long as you draw your salary from the state, the president, teachers, doctors, the judiciary, the police, the army, all the government officials, as long as you draw your salary from the state and you are on a medical aid, you've got to get a subsidy. And the subsidy is the heaviest for members of parliament and the judiciary, the judges only, not including magistrate. There, the subsidy is very heavy. I'm very heavily subsidized to be on a medical aid, that I must tell you. And
I get subsidized as ministers?
Of course, I'm telling you, everybody who draws their salary from the state get heavily subsidized. I told you, as long as your salary is from the state, you get heavily subsidized. And that subsidy, when we count it, before the recent salary increment, is 70 billion. 70 billion. The medical aid credits are 33 billion. This is the money that leaves the state to go and subsidize those people. The 70 billion is those people who work for the state. The 33 is anybody, including you, whoever you work for, as long as you have got a medical aid. So I'm summarizing to you that every year, 70 billion rand leaves treasury because it's put in your salary. Every year, 33 billion rand leaves SARS, the revenue service. It's 103 billion, which is due to those people who are well-to-do. That's why my argument last week to Dr. Maimani's Appropriations Committee, I was saying this is the only department, health, where you help the rich and leave the poor. Because in other departments, like let's look at NEFSAS, which is in the news. There is a score of about salaries, how much you earn. If you earn about a particular level, you don't win. As I was sitting there, somebody from Limpopo was phoning me about a medical and a pharmacy student who he says have failed those scores and they don't have bursaries because they said you are, the summation of the income from your parents is such that you can't get this. That's NEFSAS. In other words, the more you earn, the chances are high that you are not going to be helped. You go to SASSA, we do the same thing.
Why isn't the case with the subsidies?
You go to human settlement. When you build an RDP house, we can't build it for you. But you come to health. Is the opposite.
Why is it the opposite then?
That's exactly what you want to change.
Why haven't we changed that? I mean, that's quite obvious, Minister, that the higher you get paid as a government employee, why must you be so heavily subsidized?
How do you say it's obvious when people have taken us to court for doing the same, for saying the same thing? I'm in court now. There are 8 court cases to stop these changes.
In the last 30 years, when did we try to make the changes?
The issue of NHI started coming in
10 years
2007.
Ago? So it's been a while.
Yes, it has been a while that we've been on this, since 2007. Remember, the white paper on this issue was when I was in health for the first time. I went to Home Affairs and finished the whole term there, and I came back. Only then was the Act passed. It's something that took place over a very long period of time because it needs a lot of heavy consultation. It's a big change. It's a big transformative change, which many people don't want. So to you say it's obvious, but people are in court.
Who's fighting it?
Yeah?
Who is fighting the changes?
They are, the first one in court was Solidarity, who said it's unconstitutional. The second one was BHF, the Board of Healthcare Funders, that represent medical aids. The third one was Health Funders Association. Both of them, Board of Healthcare Funders and Health Funders Association, they represent medical aids. Then there was HASA, Hospital Association of South Africa, representing private hospital. Then there's South African Specialist Group representing some specialists, and.
So about 6
There are
people
eight.
that are 8 that have taken you to court.
Yes.
How much money
They are
are
not
you?
people, they are
Institutions, yeah.
institutions, yes.
That must be costing you a lot of money as the department to mount a defense.
It does. It does. And what we have done, we have said each one of them, you see what they were doing. To me, it was very strategic, deliberately. One, I believe these are the same people who clubbed together to cooperate, but they look like separate organizations. Because what was happening is that one goes to court, then we are forced to answer. We are forced to send in answering affidavits to court. They read them and look at what we said, then send the other one. When the other one attacks, he's attacking our responses to the affidavit of the first one. You can see. Then we have to respond to him too. Then another one comes in. They were killing one by one. So we went to the judge, the High Court in Gauteng, Gauteng North. We went to the judge and say, look, these people are attacking more or less the same case, the same principle, the same idea. Why don't you consolidate the cases so that make it one and it be heard? It can be heard over many days or a week or whatever, but it's one case at least comprising many people. They went to court to oppose that. So the hearing is in February next year about whether this case must be consolidated into one or we hear 8 different cases.
So here's the question then, Minister, for clarity. Are we sitting with a situation where we've got the NHI, but there's still no certainty about what the true cost of this national health insurance will be? There's still no certainty even about how this is going to be funded, because we're sitting with the options here.
No, I can't say this. Let's start with the funding. Clement, you need to understand the history of this whole thing, what you are dealing with. Yeah, the funding part, let's start with there. Because people say there's no money in the country to fund NHI. Now, the World Health Organization has declared that countries must spend at least 5% of their GDP on health. It's not about the budget only, it's the GDP. That means any expenditure on health, be it you waking up to go to a pharmacy and buy something, be you going to see a doctor or a public hospital or a clinic, wherever, that money is computed. And they look at what percentage of GDP is this. And it is believed that globally, if a country reaches 5%, then the money that's available will cover at least all the citizens, or at least an extraordinary majority of citizens. Now, South Africa is already at 8.5% of the GDP, which is very high. We are more or less in the same bracket as Europe, which is between 9.5 and 10% of the GDP. That money, 8.5% of GDP of South Africa, translate into 570 billion. That's more than half a trillion. It is the money that is available for health in South Africa.
But that's for health in general, right?
What do you mean
like
in general?
there are competing needs. So there's issues of infrastructure.
No, I'm saying the amount of money that is spent on health in the country.
Yes.
It's 570 billion. Yes, it's for everything.
Yes.
It's for health care of the nation. It's 5 billion, but it's divided into public and the private sector. Now, the problem we are faced with, which NHI was trying to solve, is that in this 570 billion, 51% goes to only 14% of the population. And the remaining 49% must support 86% of the population. This is where our biggest problem is, which we need to solve. Yesterday, when UNAIDS, together with the Nobel Prize laureate, Professor Joseph Stiglitz, they were launching a report on inequality, and pandemics. They've done a study to show that inequality brings a lot of diseases and pandemics in the world, which we are not able to solve. Now, this is one of the gross inequalities that we are faced with. So we are saying, if this gross inequality is brought to an end, in the way I've told you, tax credit, subsidies, etc., the money will be enough to cover a large number of the population, if not the whole population. And you can't just say there's money around. You have to make rules. You have got to make laws about how it's going to happen. And you have got to amend the manner in which people take care of their health. For instance, just to give you an example what I'm talking about, at the moment, our health care is very curative. Very, very curative. Private health care is 100% curative. Public, we're trying, but whereas healthcare systems must be preventative. You must prevent diseases, promote health, immunize people, stop others from getting any disease. You can't just say, look, just pay me, just join a medical aid. When you are sick, I've got everything to fix you. Healthcare system doesn't work like that. Number two, our healthcare system is top, bottom. Whenever you are sick, you start at the bottom. We have got professors or very senior specialists who treat flu. It shouldn't happen like that. It shouldn't happen like that. It's not, just to give you an example, it's not like that in law. You have never had anybody go into senior counsel without starting with an attorney. It's an attorney you go to who said this case is bigger than me. Yeah. The other cases, if somebody stole your gold, for instance, that will never reach senior counsel. An attorney can deal with it. And a small magistrate court, very small at the corner of the country, can deal with that. That's not so in health. It starts right at the top. You have got very senior people who trained for many years treating mundane issues. And the NHI wanted to reform all those things. That is unfair to the country because it becomes too expensive.
Yeah.
Take, for instance, myself. You are aware that I've just done my 2 eye operations in a public hospital in St. John's at Bara. There were debates about this whole thing. Some were even saying I've put my own eyesight at risk by going to a public hospital because they believe I'm rich enough, I've got medical aid, which is true. I've got one of the most heavily subsidized medical aids. But they expected me to go and spend a lot of money, if you understand what I mean. Unnecessarily so. Now, we want to change such systems dramatically. The last example I can give you. In the past year, Bara, which is always in the news for quite a number of negative things, never the positive, even if they are there. Bara did 500 operations on the knee, replacing somebody's knee and the hip and knee operations. Bara did 500 of them. These are huge operations to replace your whole hip or your whole knee, right? They will have cost maybe 143,000 for one person or 135,000 for one person if you go to a private hospital. But they will cost something like 18,000 if you go to a public hospital, if you understand what I mean. So there is a possibility of running a healthcare system that is affordable. Mm-hmm. If you go to do a circumcision now with a GP in Soweto, they will charge you between 1.5 to 1.8, 1,500 to 1,800. If you go to a private hospital, you are going to pay 15,000 to 18,000 for the same procedure.
25 minutes before 11 o'clock, we're in conversation with the Minister of Health, Dr. Aaron Motsoaledi, and I've got your calls on 011-883-0702. I've got some of your questions on the YouTube line, on WhatsApp as well. Let's start with Nicholas, who's calling us from Newcastle. Nicholas, good morning.
Good morning, Mr. Manyathela. How are you?
Sure, man. Go ahead.
Okay, thank you so much, man. My name is Dr. Nicholas Mchali. I'm a Cuban trained. I was trained by the Department of Health from KZN. So now, Mr. Manyathela, if you remember the beginning of this year, I once called with regards to the unemployed, especially the bursary holders. We were trained by the Department of Health, but now the same department is failing to employ us. I'm sure the minister know about the issue of unemployment, especially us, because now we were trained by the same department. The department spent millions of rand in Cuba trying to train doctors, but now the same department is failing to employ us. It's almost a year now, but nothing.
When did you come back, Nicholas?
I came back in 2021. I completed my community service last year.
Okay. Nicholas in Newcastle, thank you so much for your call. Minister, I do remember there was a time there was a briefing and you were committing to hiring, if I'm not mistaken, 1,200 doctors, 200 nurses as well during your budget vote. Have you been able to go ahead with that?
Firstly, let me correct. It's not only Cuban trained doctors. It's all post-community service doctors, regardless of where they were trained. We could not employ them. And the biggest problem was this budgetary constraints, because health have suffered austerity for the past 10 years. But in the budget speech that the minister read this year, after the war about VAT and all that, he eventually read the budget speech. He said to take health out of austerity. He gave us 6.7 billion rand. We said as the National Health Council, the National Health Council is a statutory body chaired by the Minister of Health, consisting of all the MECs, the Surgeon General of South African Military Health Services, and SALGA. We sit together and we decided what must we do with this money. And the first thing we said, we'll hire the 1,200 doctors who are post-community service, who don't have salaries. But we have to wait for Treasury to distribute that money, because I wanted it as conditional grant. A conditional grant is the money which is given to the minister, and you give it to the province with conditions. But Treasury insisted on giving it as equitable share. Equitable share meaning it going into the province directly, and they can do, in terms of the law, they can do what they want with it. So in order to try and stop that, I wrote to all the premiers, informed them about this money, because it was divided, this 6.7 billion was divided into four. The first amount to hire this 1,200 doctors, 200 nurses, 250 health professionals. The second amount to absorb community health workers, 27,000 of them. The third amount to buy 1.4 million articles, beds, bassinets, linen, towels in hospital to spruce them up. And the last amount to pay for accruals, the people who, service providers who give us particular commodities we couldn't pay for. So I've just written to premiers, I think it's about 10 days ago, to say this money is going to come into our provincial budget. Please do the following with it, because we agreed at national level. We then also agreed that the adverts must not be done per province. The provinces must send us the adverts here, because the money is with them, meaning they are the ones who knows in their province how many doctors they can hire. When I checked by yesterday, they were left with a few provinces to bring in. Then we'll put the advert. We delayed because we had to wait for Treasury to transfer the money to provinces first. We couldn't just say advertise at national level when the provinces are not having the money.
What's the vacancy rate for doctors and nurses in public hospitals?
Oh, it's a difficult question for me. Because I need to go and look at PESAL. I can't just say it off my head. I have to look at PESAL, because the vacancy rate is also a moving target. It depends at what time do you ask. You go to PESAL and check which posts have been filled and which have not. So I'm not able to answer that question right away, but I can go and check and give you the answer.
Fatima on the WhatsApp line says, Clement, I'm still very much concerned about the level of corruption, even when it comes to the NHI, because we have corruption that already exists within the department. You look at the hospitals, how much more would be up for grabs come the NHI. And of course, Minister, you know about what happened at Tembisa Hospital, 2 billion rand looted according to the SIU. Given the systematic nature of corruption in healthcare procurement, is the department considering an overhaul of how hospitals handle tenders and suppliers?
Oh, yes, definitely. Definitely. We have actually already started. But I want to start here, Clement. There's no NHI in South Africa now. And you saw this corruption in Tembisa under the present system with no NHI. But funny, people blame NHI, which does not exist. Every time, even yesterday, there's a journalist who asked me, why are you talking about NHI when there's so much corruption? The corruption is now under the present system, under the present acts.
But it could happen during NHI too.
It could happen, but it has not happened.
Well, that's what the president said about COVID when we asked. He said there won't be corruption during COVID.
No. I don't know, because I don't know under what condition was he speaking. I'm speaking from the act of NHI, how we have put up the act and what is going to happen in terms of the finances, what boards, what committees, how do the public choose them, how do they account and all that. We have got all that. Now, let me come to the present situation about corruption. Yes, we immediately after the SIU reported, I called the SIU to have a workshop with my officials to find out in all the systems we are using, based on the finding of SIU, where could there have been a gap for somebody to steal? So we spent the whole day doing that. The next was to go to the National Health Council, which I've already mentioned, call all the MECs and their officials and their CFOs. We even included the biggest, the academic hospitals, to attend that meeting. SIU came again and presented what happened in Tembisa, step by step, and showed them where the gaps are. As I'm speaking, we have got a workshop coming in, I think it's in the next week or 10 days, for all the hospitals in the provinces first, their head offices, to say, look, this is where the gap was in Tembisa. But the other important thing is that if you read the SIU report, they say all the systems are there. They are there. But people decided to breach them deliberately, which means this was in the minds of people who had a criminal mind, if you understand what I mean, in both Tembisa Hospital and the Provincial Department of Health in Gauteng, because all of them were involved. The syndicates, the three syndicates of Maumela, Matlala, or whoever, they could not have achieved what they did without the cooperation. That is why one of the things we are doing is to go to concentrate on the people in the provincial department in Tembisa who did this. They've got their salaries and their pensions with us in the state. They've bought property. We're all targeting those. Should these people, if they go through DC and get fired, what must happen to their pensions? That money must be paid back, whether it is with Morgan Hangwane Maumela or whoever. It has to be paid back, and there ought to be consequences.
Yeah.
Now the workshops is to change. For instance, one of the things we identified, which was the method used, is that because there are always emergencies anyway in government, the law says that anything that is 500,000 or less, you don't have to go through a normal procurement process. You can just call for quotations. In other words, you call for companies to give you quotations, and you call for 3 quotations, and you look at which one is more affordable among the quotations. Now, we have found that what we're doing in Tembisa was just to go below the 500 and say 499. So it forces them to go for quotations to avoid normal procurement rules. And we have just got worried because Treasury has just increased that 1 million, which means we are going to see many 999s. So I raised this issue, even with the SIU and Treasury. Under what conditions should we go for these quotations? Because they cause problems, very serious problems. How do we avoid the quotations? But secondly, to look at the issue of endorsement. After all these procurement processes have gone through, somebody senior must endorse. At what level and how many people? Because to corrupt many people is very difficult. So those are the things we are looking at.
Are you looking at other hospitals as well? Because, I mean, you've said before that Tembisa is probably just the tip of the iceberg. And I wonder how many other hospitals or provinces are currently probably experiencing the same thing.
I don't want to say the tip of an iceberg, because there are provinces hospitals in the country that are run very well. And I don't want to discourage them. There are those who are run very well, which don't have Tembisas, because it's not all the workers who are corrupt, Clement. Even in Tembisa, the person who allowed this corruption was the CEO, because he's the final accounting officer who signs off everything, if you understand what I mean. People don't just go to these quotations and procurement and buy. They've got to go to the CEO and show him. So it means he didn't pay due diligence. But we believe he was part of the syndicate. Unfortunately, he has passed on. And I was saying it might look evil. We must go for his estate. Now, if you check all the other hospitals, they've got CEOs who are not capable of this theft or who don't want to do this theft. And it will be unfair to point at them and say they are just like Tembisa.
But you do want to check if the syndicate is not operating in other hospitals.
Oh, yes. In fact, what we did was to ask the SIU, because these syndicates have already learned the modus operandi and they've corrected some officials, why shouldn't they be blacklisted? So that they don't do any dealings with government anymore. And we've got nobody to tempt officials into corruption. Or to induce them into corruption or to do corruption with them. So they told me it's only Treasury that can blacklist a company. And so SIU have sent the list to Treasury. We are waiting for that blacklisting. I then said, but in the meantime, what should happen? And we asked that SIU, because they've got this list of all these companies, must distribute them to provinces and the hospital, so that when the CEO, when they put documents in front of the CEO to finally approve, he can see that, oh, this is Clement Manyathela company. It is on that list of SIU, but they say he qualifies. Let me do further due diligence. There must, in other words, to be more alert. So I have asked for that list to be distributed. Obviously, people will say it's unfair because they've not been blacklisted. And you can't deny them a contract. But I want double due diligence for somebody who must take a decision as a CEO, sitting in an office, see that this is one of those companies. How did my officials allow them to go in? Was it legal? Let me go to check. And you dig deeper. You may actually find something.
Has this system of tenders really served us?
I don't think so.
So why are we not changing it?
I don't think so. They have been moved about how tenders must be changed, but Clement, that is beyond my pay grade, because it depends on the chief procurement officer, treasury, etc. But
I think it depends also on you. You've been the governing party. Don't you talk about these things as at NEC level to say, hey, comrades, you are stealing, man, in the government, and there are some public officials who are also stealing. Therefore, we need to tighten the screws.
Yeah, it is said. That's why the screws are being tightened.
But it's still
at
tender
the moment.
system.
But as I'm saying, the issues have been raised. I personally, I'm giving my feeling, I'll be very happy if we look at another system, not the tender. For instance, just to give you an example, I told you that we're going to buy 1.4 million articles in hospital. These are beds, electric beds, bassinet for kids, blankets, sheets, etc. As a chairperson of the National Health Council, I demanded that we don't go for a tender for this, because in Silverton, here in Pretoria, there's a project established by the Department of Labour and Employment, which project is run by disabled people. They produce these things. Linen, sheets, even theatre gear and all that. I say, why can't we buy from them? Last week, we went to the Minister of Finance and say, can you give us a letter exempting the Minister of Employment of Labour from going through the tender when these disabled people can do this work and you can buy from them? And there's an agreement that must happen. So bit by bit, we'll move away from tenders wherever we can.
Dumelang, welcome to the third and final hour of the Clement Manyathela show. Thanks for staying with us. I've asked the Minister of Health, Dr. Aaron Motsoaledi, to stay for a couple of minutes just to get his reaction to the judgment that's just come out of court. The court has declared Operation Dudula's conduct as unlawful, and now the movement has been interdicted from blocking clinics. Remember, they've often gone to clinics, they've tried to say foreign nationals should not be allowed in, but the locals and South African citizens must be prioritized. They have argued that we've only targeted illegal foreign nationals. Minister, I just want to get your response to that, because this is a concern that was raised by the health department about their conduct.
Yeah, well, this was to be expected. I personally told them that. Remember, I did meet Operation Dudula, and I came public about what we discussed. And I told them that whatever concerns they have, some of which might be legitimate, by the way, but I said they are going about using a wrong method to achieve their goals. I even told them, because they said to me, they can accept or understand that doctors and nurses have taken an oath. They can't turn anybody away. But they were asking me to instruct the clerks who are issuing the files that anybody who doesn't have any papers or any identity or documentation cannot get a file in the hospital. They must send such people away. I told them that I happen to have been in Home Affairs. I know that 11% of the South Africa's population do not have any documents. I'm talking here of South Africans, not illegal immigrants. Because on the continent of Africa, we've got this problem of civil registration and vital statistics. And we know, we do have figures, that number one on registration on the continent is Egypt. They are 98% registered, which means there are 2% Egyptians who don't have any document. Number two is South Africa, which is 89% documented, which means 11% of South Africans don't have documents. So it means they too will be turned away from health services. So I told them that method cannot work, and there are many reasons why it can't work. So I'm sure the court is just legally or officially, in terms of their power, finalizing exactly what we've been knowing.
Yeah. Are you having conversations, though, Minister, with the governments where most of the foreign nationals who are using our public hospitals are from, or even the embassies for that matter? Is there a conversation around how we can sit and find a solution? Because the reality is their civilians are here. Whether they're here illegally, that's a conversation we can have, but they're using resources. Is there no way we can work together on this? Because that's costing money.
Personally, I don't think they're interested in helping us. I must be very honest. Because what is biting them? It is South Africa which is suffering, not them. In fact, many of them are relieved. Some of them, let not me be mentioned a country. When you mention to them, they said, look, we haven't expelled anybody from our country. We haven't sent anybody to South Africa. If you South Africans welcome anybody who comes there, it's your own problem. Solve it there. Don't come to us.
That's Zimbabwe.
I never said
Isn't
so.
it? Yeah.
I
see it in your eyes.
I never said so, Clement. Those words come from you, not from my mouth. Please.
Because I've heard them say that. I've interviewed the Zimbabwean ambassador, and he has said similar things to me. Because I've asked him, what responsibility do you take? Why are you not working with our government to try and resolve this? Because it's a burden that falls on us.
Yes. And he told you that? Well, that comes from you, not from me.
Not in so many words, but he was like, well, that's yours. We never said anybody must come to South Africa to come and use your resources.
That's where the problem is. So what I told Operation Dudula is the problem we're having, Clement, which you need to solve very fast, is the issue of having a health information system that can make you trace patients. Let me explain in short what I mean. You saw the medicines that were crossing the border there, to Zimbabwe.
ARVs.
Yeah, people were saying they were stolen. And I said they might not have been stolen. They might not have been stolen. it might be prescription from doctors who give them legally. Because what we know in SEPIN is that people move from clinic to clinic collecting medicines. Even South Africans do, by the way. You can move from one clinic, give you medicine, you go to the next. People hoard these medicines. So even South Africans unfortunately do, but it becomes worse if it's somebody from another country. So the solution is to come up with a health information system that links all the health facilities, all the health professionals, all the doctors, public and private. Now we have been working with CSIR for the past 8 years to have such a system. It is there. It's called Health Patient Record Registration System, HPRS. We have just piloted it in the Free State. We are connecting hospital to it. Once it is up and running, you'll be able to catch and say, but you collected your medicines yesterday or 2 hours back. You collected this medicine because we are in such and such a facility, or you saw such and such a doctor. That can help us tremendously.
Okay. Minister, thank you so much for making time for us, and thanks for giving us a couple of more minutes of your time.
Thank you.
It's 13 minutes now after 11 o'clock, and it's time now for our World of Work feature.
Clement is on X.
At The Real Clement M.
So, on our World of Work feature this morning, we're discussing how to deal with grief when you are in the workplace. Grief is part of life, and as an adult, you take your grief wherever you go, right? This is not something you leave at home, and that includes taking it into the workplace. And we live in a world that pushes productivity and performance, and many workplaces, if we're being honest, are not even equipped to deal with loss, whether it's the death of a loved one or the end of a relationship or any other major life change. So grief in the workplace can show up in so many ways. There are people who will miss deadlines because they are going through grief. They'll have glazed over eyes, unexpected outbursts, you name it. So the truth really is that grief doesn't really stay at home. And I want us to have a conversation about how we can deal with grief in the workplace, but also as employers, what you can do to support your employees who are going through that. Anya van Beek is a talent and culture strategist, leadership and HR expert and executive coach who's going to guide us through this conversation. But I'm also interested in your own reflections and your own experiences of how you've dealt with grief in the workplace. I mean, many leaders overlook that grief isn't just emotional.
Hanging out with Clement
On 702.
Let's walk the talk.